Let's see if now this is on. Now this seems like it's on. Good morning. Welcome to Grand Rounds. Welcome to those who are logging on Zoom. I can't tell if there are a lot of people on Zoom, but hopefully there are. Welcome to April. And we are excited about today's Grand Rounds topic. But a few announcements first. So the next Grand Rounds will be our new drug and device update by Dr. Richetti and Dr. Lineber. So please join us April 17th. Next Journal Club is April 10th. That will be on Zoom. I wonder if we can turn down like the rest. Okay, perfect. Thank you. We're all good. So we do have Journal Club in a week on Zoom. Today, after this, we have Geriatric's division meeting. Also today, there is a potluck over in Anschutz Health Sciences Building, room 6112. So on the 6th floor, everyone is welcome, even if you did not bring a dish. So especially want to be there to connect with our researchers and our research fellows. You will also receive an email after Grand Rounds today with our PowerPoint and our evaluation and all that good stuff. Okay, so moving right along. Dr. Gates, we are really excited to have you presenting today. She completed her family medicine residency here at University of Colorado after attending University of Cincinnati for medical school and University of Notre Dame for undergraduate. Her clinical interests are full spectrum primary care, health equity, and medical education. After completing fellowship, she will begin a career with the University of Cincinnati doing primary care, nursing home care, and education of family medicine residents. Outside of medicine, she loves to be outside with her son Leo and husband Scott. So really excited to hear about this topic, health insurance literacy, how older adults choose and use health insurance. Welcome.
Hi, everyone. Good morning. I'm Maddie. I think I know most of you, but everyone else, nice to meet you. I got interested in this topic of kind of health insurance and health policy. Actually, back in undergrad, I took a health policy class as part of my science, business, and poverty studies major and minor, and actually wrote my undergraduate thesis about different care models for patients with diabetes. And then I was a little bit shielded from this in residency. My primary care clinic was at Denver Health, where there was very little insurance variety in our patients. So a lot Denver Health Medicaid, Colorado Medicaid, and then the various Denver Health payment plans and scaled payments. So I actually didn't have to worry about this all that much in residency. And now in fellowship, I was exposed to kind of all the many different kinds and versions of Medicare and insurance that our patients have. And then Dr. Mandy Pang pulled me into a survey that she was creating for the seniors clinic patients about Medicare Part D and their understanding of Medicare Part D and how they chose that. So I spent the past couple weeks to months reading a lot about this topic, and I think it's something that we encounter all the time and something that there'll be lots more research in the future. So a little bit of a primer. Our objectives today, and this is my son Leo. He's very passionate about literature, and he is not quite literate yet, but on the way, so he will pop up. But today we're going to define health insurance literacy, describe methods of measuring health insurance literacy, understand why it's important for the medical care of older adults. We'll name ways that older adults get help making health insurance decisions, and identify how providers can play a role in patient health insurance decisions. So first, some definitions. We'll start with just literacy. I think at base level, we think about literacy as like, can someone read or not? But it's a lot more nuanced. So the CDC defines literacy as understanding, evaluating, using, and engaging with written text to participate in society to achieve one's goals and develop one's knowledge and potential. And very similarly, numeracy is the ability to access, use, interpret, and communicate mathematical information and ideas to engage in and manage mathematical demands of a range of situations in adult life. So it's not just being able to read the words or the numbers on the paper, but actually being able to use that information to succeed in life. Then we have definitions for health literacy. Personal health literacy being the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Then organizational health literacy is a little bit about how an organization kind of facilitates personal health literacy for patients and employees. Then, to get even more specific, a newer concept of health insurance literacy is the degree to which individuals have the knowledge, ability, and confidence to find and evaluate information about health plans, select the best plan for their own or their family's financial and health circumstances, and use the plan once enrolled. So, we're really seeing this theme of it's not just about reading the information on the paper, but being able to use that information to choose a health plan and then use that health plan to its best ability. Today, we will focus a little bit more on the choosing aspect of it, but that's not quite the whole story. So let's look at some data about literacy. This information comes from the National Center for Educational Statistics, a large survey that has been done in multiple cycles starting in 2012 up through 2013. These numbers are for the average literacy and numeracy in the United States in adults aged 16 to 65. As we often see, our older adults are not always included in all of the studies, but their goal here was to look at like working age populations. So these like numbers in the 200s are really somewhat arbitrary, but to give you the background, their scale is from 0 to 500, with this 200 around 250 being level 2 literacy. So we're really getting to this literacy more of as a spectrum than is someone literate or not. This level 2 literacy, where all of these numbers are falling, is really someone who's able to look at kind of a longer piece of text, maybe even make inferences and pull information from kind of multiple places in one long text. Someone with level 1 literacy would struggle more with that longer text or multiple sources, but would be able to succeed in like a short paragraph, more focused with less distracting information. And someone with level 3, which is right around 300 and above, would be able to use like multiple documents, multiple sources to make to get information. For a little bit more context, too, this was actually an international study conducted in 30 studies in 30 countries in North America, South America, Europe, and Asia. The international average in 2012 was right around 250, or it was 267 for literacy and 263 for numeracy. So the US levels are really very similar to that. The highest performer in 2012 was Japan, with a literacy level of 296, which does fall into that level 3, and numeracy of 288, also in that level 3 category. This graphic kind of breaks down the population into what percentage of people are in each level. Really, one of the big takeaways I want us to see is not just that at least 28% of the population is in that level 2 or below, but that we're not really seeing improvements in this score. We're actually seeing a statistically significant decrease in literacy levels over time. So then let's drill into health literacy itself. This is kind of a scale of health literacy done by the same, also by the National Center for Education Statistics, that kind of follows a similar pattern in what we just talked about with the levels, and I'll give you some more zoomed in details. But people in the proficient category on average could find the information required to define a medical term by searching through a complex document. Someone in the intermediate range could maybe determine a healthy weight range for a person of specific height based on a graph with BMI. On the lower end of that intermediate scale, could identify substances that may interact with an over-the-counter drug to cause a side effect using information from the drug level. And I really, as I've read about this, have used that as kind of an anchor point, that intermediate level health literacy of someone being able to look at an over-the-counter drug and see how it safely applies to their life. In the basic level literacy, we're looking at someone able to give 2 reasons a person with no symptoms of a specific disease should be tested based on information in a clear, more simple pamphlet. And then below basic, someone being able to circle the date of a medical appointment on a hospital appointment slip. So when we look at the U.S. population, and this is actually for adults 16 and up, so it does include our older patients, we're seeing that 14% of people, and this was in a study in 2003, so a little bit older data, but 14% of adults fell in that below basic category, meaning that they could circle the date of an appointment on an after visit summary, but probably not process the information on an over-the-counter drug label. 22% of people being in that basic level, 53% in intermediate, and 12% in proficient. So my big takeaway here is we can sort of think that maybe a third of our adult patients have trouble navigating the drug label on an over-the-counter drug. This is the health literacy broken down by ethnicity. And I think the big takeaway here is that as we maybe could have guessed, this is also a little an equity issue, right? We're seeing that people who are self-identified as Hispanic had a much higher rate of below basic level health literacy. And certainly we can expect that language might play a role in this. This survey was done all in English, so anyone who had English as a second language might struggle more. But then here we go. Now we're looking at our patients in that for our patients or for participants age 16 to 64, we really see like a pretty steady level. All these percentages look very similar. But then when we zero in on people age 65 and above, we see a pretty obvious drop off in health literacy at that age. So we have talked about literacy, numeracy, and health literacy, but then how do we get even more specific and measure health insurance literacy? Like, how do you test for this? What do you need? What skills do you need to have to be able to choose your Medicare and use it? Do you need to be able to have reading comprehension? Do you need to like know all the terms? How much math do you need to be able to do? And then if you do develop a test, how do you decide a passing score? Like how much do you have to know about your insurance to use it successfully? Like how do we define success? Groups have attempted in different ways to measure health insurance literacy. And if you look at the writing about this, most researchers will kind of make up their own way. And so it's really hard to compare across studies, but we'll talk about a couple of frameworks. There's one validated score called the Health Insurance Literacy Measure. That's one of the more cited items that we'll talk about. But we'll see that it did not include patients above the age of 65 again. So let's look at some proposed frameworks, starting with the Health Insurance Literacy Measure. This group kind of in developing their assessment thought, well, maybe health insurance literacy requires knowledge, so like knowing even insurance terms, information seeking, so being able to figure out what questions do I need to ask, document literacy, being able to look through Medicare documents and find what they need, cognitive skills, so kind of like assessing what their personal needs are, all coming together with self-efficacy, so the confidence to be able to make those decisions. They created kind of one set of self-assessment questions where people rated their competence in their ability to do certain health insurance tasks, and then one set of objective skills questions. They found that their conceptual model didn't really fit the data, that they couldn't drill that specifically into these kind of different skills needed, but really saw these broader categories of being able to choose and to use insurance. And like I said, unfortunately, no one older than 65. Just a little bit of data results from this study. They saw that health insurance knowledge and skills in their work seemed to increase with age up until the age of 65. Interesting that we saw in the previous work on health literacy that we saw scores be very stable until the age of 65 when it seemed to drop off. And they also saw a pretty obvious increase in health insurance knowledge. And this is just percent of questions answered correctly. A pretty obvious increase with higher income levels. So what about health insurance literacy in older adults? Another group created a kind of more confusing looking framework, but really based a little bit more on financial literacy and what has been found to be required for high level financial literacy. This group created similarly terminology items and proficiency items. They used actual Medicare documents. So in this survey, they would give people, this is an EOB. Can you find this information, an explanation of benefits? And fielded the survey as part of the longitudinal Medicare current beneficiary survey. They found that some of the terms that people were least able to correctly identify included provider network at only 41%, formulary at only 44%, and Medigap at 56%. Questions about explanation of benefits forms were especially difficult for participants. This is really, really small, but I'm going to highlight the things that I think are the most interesting. So when we break it down by age, and again, this is just percent of questions correct. This was not like turned into any kind of score like in the previous work, but we kind of see almost a little bit of an increase up until the age of 74 in the percent of questions correct, and then a bigger drop off at age 85. And in general, you'll see that the percentage of terminology questions answered correct in all of these categories was often less than the comprehension questions. Again, we see differences by self-identified race, with, in general, the population in white people who self-identified as white getting 71% of the terminology questions correct. Patients who self-identified as Black only getting 58.7% of the questions correct. So we see less of a difference between the reading comprehension questions. And then down at the bottom, I think another really interesting point is the differences we saw based on the insurance type that people reported to have, specifically participants that reported having Medicaid or other public insurance struggled more, again, with the terminology questions. Again, less of a difference with the reading comprehension questions, but we really saw that difference stand out more with the terminology questions. So what about our patients at the seniors clinic? How health insurance literate do we think they are? Dr. Pang and we developed a survey with input from the University of Colorado's actual health literacy team. So we'll talk about that a little bit more at the end, but there's a group of people who will help you read your documents and make sure that they are appropriate for our patients. This paper survey was given out to clinic patients from around October through March at Seniors Clinic here at AMC, at Lone Tree, and at Kavod. And we had a little over 100 responses, 45 from AMC, 29 from Kavod, and 28 from Lone Tree. The first question was just, what part of your care does Medicare Part D cover? And I also think this is kind of interesting because this is like almost a board question or like a step question. And they could select all that apply. We saw that 64% of respondents included medications as part of their answer, but only 34% correctly identified that it's just medications. At Kavod, 21% of people got this correct, just answering medications. At AMC, 44%, and at Lone Tree, 25%. I think this is so big that only 34% of patients got this completely correct. How did people enroll in their Part D plan? 14% said they chose based on information online from Medicare. 18% of people used an insurance broker, which we'll talk about in a few minutes. And a third of people said they don't really even remember. They've just had the same plan for years, which is very consistent with a lot of what other people who've written about this have found, that people are very unlikely to switch plans. Once someone is enrolled, there's a lot of inertia. And even with presented information that there's a better plan out there for you, people are very unlikely to switch. What was important to people when they made their decision? 51% of people said whether their medications were covered on the drug formulary, which I think is super interesting, how we saw previously that only 44% of participants in the survey of Medicare beneficiaries knew what the formulary was, but yet we're seeing how important this concept is to patients. 42% answered the amount I have to pay for services or the deductible. 53% answered that they do know the cost of their deductible. 54% said they know the cost of their monthly premium. And then this question I think was very interesting, and I was hopeful to have different results, but I think we still got something interesting. So we also asked if people knew their out-of-pocket maximum. So every year Medicare Part D sets an out-of-pocket maximum for patients that is the same across all plans. For 2025, it's $2,000. So we asked people that question. We said, do you know this number? 36% said they knew the number. But then we also asked them, okay, what is the number? And of the 16 people that gave us a response to that, 4 of them correctly said $2,000. I do think part of this is a little confounded because there were certainly some people who answered this survey who very clearly didn't actually have Medicare Part D. Some people just straight up wrote on the paper that they don't have Medicare Part D, and some people clearly answered the questions based on their Medicare Advantage plan. So I think that in some cases, some of these people who gave other numbers might actually have been correct about their own plan. But I do still think overall, the fact that only 4 people out of the 102 surveys I looked at knew that the Medicare Part D out-of-pocket maximum was $2,000 is very interesting. Yeah, these were all the other numbers I got. And then for if someone answered no, they could say, do you know where to find this information? And 70% of people said yes. Some just interesting comments that people wrote in the corners about Medicare Part D. I do not have it, but wondering if I should. I don't have Part D. I never have had it and have not needed it. I only take 2 medications and they are not expensive. Super interesting because one of the important aspects of insurance is that you're protecting yourself against future costs. And that seems to be a concept that a lot of people struggle with insurance, that picking a plan that works for them now is great, but protecting for themselves, for their future selves is a lot harder of a concept. I love this one. This caps and underline were from the participant, not from me. It is important that I have no advantage plan, so I keep my separate D, no combined plans. One person when asked how do they enroll in this Part D plan, they answered other and said TV. And then another person said, not sure I have Part D, should I? Question mark. All right, let's see if you guys have health insurance literacy. This multiple choice question comes from the health insurance literacy measure. So this was one of the measures that didn't include older adults. But here's your question. Early in January, Robert visits an in-network doctor to get a wart removed from his foot. The bill for this visit is $530, which is the member rate the doctor agreed to charge his health plan for that service. Robert has a $30 copay, a $100 deductible, and 20% coinsurance that apply for this visit. His copay does not count toward the deductible. How much will Robert pay for this visit? I'll give you a couple minutes. All right, now comes the time where we figure out if I remember the tech stuff that we set up at the beginning. Okay, great. So it looks like we have about a third of you said the $130. Oh boy, maybe I didn't. There we go. Okay. We have 11% gave 210, 44% said C, the 236. And then I appreciate the people that were just like, this is too much for me. I don't blame you. It's too much math. All right, so the correct answer is number 2, $210. In the HILM in the data, only 28.6% of respondents answer this correctly. So if you got it wrong, don't feel too sad. So this is how you would do it. You subtract the deductible and the copay from the total charge. Then you calculate the coinsurance. Then you total the deductible, the copay, and the coinsurance together. I know. I picked one of the hardest ones. Okay, here's another one. So in actually both of these 2 studies, they asked people to describe or define the health insurance formulary. This in the surveys was actually a multiple choice question, so I made it harder for you all. But I want to see what people think the health insurance formulary is. Oh, I have to activate it. Thank you. Okay. Yeah, so someone answered that they've never heard of this term. They have no idea. Someone answered it's the list of drugs that their insurance will cover. And that is the correct answer. The formulary is the list of medications that your insurance will pay for. When I practiced this for my husband, he also had no idea what this was, and he has a college degree. And so this is a word that we as providers think about a lot, and it's not something I realized that was a concept that patients don't have a good grasp of. It's something that I definitely took for granted that my patients knew. In the survey of older adults, the Medicare beneficiary surveys, we saw that 44% of participants got this question correct. In the HILM survey, only 36% of people got this question correct. Here's a breakdown based on a couple self-identified characteristics. Again, we're seeing patients that self-identify as white performing a little bit better than Black and Hispanic patients, and English-speaking patients performing better than Spanish-speaking patients. This next one has no poll everywhere, so I'll just let you guys think in your head if you think you know what these terms mean. And if you're getting stressed, don't worry, so is Leo. Um, so one term they asked about was appeal, which 80.9% of people knew what that was. Assignment, which I believe refers to like being assigned to a patient panel, although the paper didn't tell me exactly what that was. But formulary, we're seeing 44%. Preventive care, 85. Generic drugs, only 75. Outpatient care, 88. Provider network, only 40%, 40.8. Primary care doctor, 89. Deductible, 71. And Medigap, 56. I think, again, formulary and provider network stand out to me. It seems that the concept of the insurance restricting someone's access to what they can have in the medical field is not a concept that is one of the harder concepts or parts of insurance. And it's such a important thing that I think we think about a lot, particularly the formulary. So why does this matter? I think we can think logically that it's important for someone's health to be able to know how to use their insurance, but does the data kind of bear that out? There is a lot more evidence in this topic related to health literacy itself and health outcomes, but some newer evidence about health insurance literacy in particular. So based on a prospective cohort of Medicare Advantage patients, inadequate health literacy as measured by reading fluency independently predicts all-cause mortality and cardiovascular death among community-dwelling elderly people. Patients with lower health insurance literacy are less likely to use preventive services. And this second bullet is based on a smaller survey, but is kind of echoed in other research in other places. Patients with health insurance literacy are less likely to use preventive services. I think this aspect also stands out to me because preventive services should really be free to someone regardless of their insurance. And so there, I think, is also not only does health and not knowing about your health insurance and how much something will cost keep you from doing things that are actually expensive, but it will keep people from doing things that are actually free to them. And now, of course, even if there is no copay, no deductible, like the visit, you don't pay anything for the visit. Certainly childcare, taking time off does make a preventive care visit cost something to someone. But I saw it in multiple places that people are foregoing preventive care when they don't understand their insurance. Self-reported poor familiarity. So again, not based on an assessment, but just on patients' self-reported familiarity was associated with multiple emergency department visits, lack of prescription medication use, poor perceived access to care poor overall health and greater reported decline in health in a survey of 3,000 Medicare beneficiaries. And higher health insurance literacy has also been associated with lower medical debt. This is in a survey of kind of more middle-aged adults, 50 to 64, but I still think important to think about. It's also important because theoretically, regulatory people and government agencies are starting to care a little bit more about health literacy as well. Healthy People is an initiative that was originally created back in 2000 that sets goals every decade to track progress on national health and preventive goals. Healthy People 2030 was released in 2021. So this is the goals we're trying to attain by 2030. This does come from an advisory committee put together by HHS. So I will say that as I've been looking at this intermittently over the past few weeks, you will find that sometimes the website's down, sometimes it's there. Unclear how much of a priority this will continue to be over the coming years. But health literacy is a major priority as part of Healthy People 2030. There are 6 specific measurable objectives in Healthy People 2030 that relate to health literacy. And a lot of them do actually put a significant amount of the onus on providers. Things like increasing the proportion of adults whose healthcare provider checked their understanding, decrease the proportion of adults who report poor communication with their healthcare provider. So all of this is getting more attention from people that study healthcare. You can actually click this link and it will take you to the Healthy People website and give you like up-to-date information about how well we're doing in these areas. Again, this website is like intermittently working or not. So this is from yesterday. We saw that there's really been little or no detectable change in most of these specific measurable areas, which, to be clear, is like the case for most of the objectives right now. So what insurance choices do people make in the United States? The most basic choice is whether or not to have insurance. In its original form, when the Affordable Care Act was passed, it did include a health insurance mandate, but in the first Trump administration, that part was removed. So people do choose whether or not to have insurance. People sometimes have the option to choose employee-sponsored plans. They might use marketplace plans. They might choose to enroll in Medicare or Medicaid, and then the various parts and choices that are a part of Medicare. And how do people make these decisions? There are state and federal marketplaces. There's the CMS website, brokers, state health insurance assistance programs, which are something new to me that we'll talk about here in a minute. And then, of course, family, friends, and TV. So I took a little journey through the Colorado State Marketplace. This does not necessarily apply as much to our patients that are older than 65, but still very interesting. So I thought, what can I get for myself, my family, myself, my husband, Scott, and my son, Leo? So first, I just, as anyone would do, I just Googled Colorado Insurance Marketplace. Interestingly, the first 3 things were like sponsored private websites that help with the choice. I had to scroll down to find the actual official government website. It had me enter my name, date of birth, and income to see if I qualified for financial assistance, which I did. And this could take us on a whole nother grand rounds of how a PGY4 medical trainee salary cannot support a family of 3, but a topic for another time. Ask me about it afterwards. But the state would help me with up to $616 per month for insurance on the marketplace. Then it asked me to predict my healthcare utilization as low, medium, or high. This was kind of tricky for me. Like, to get into the medium category, you would need to have like a hospitalization, which it's really hard to predict if you're going to have a hospitalization or not. And then optionally, you could list providers and medications that you specifically want to make sure were covered. I did not list providers and medications. And then I was given a choice between 85 different plans. The website was actually pretty nice, honestly. So this is the first 3 plans that were suggested for me, and you can see all the different costs broken down, and there's little like question marks that you can hover over and it will explain the terms to you. And you can sort based on like the yearly cost estimate, the deductible, the premium. So a lot of information, but I was pretty happy with how easy access to like real-time help was. Regardless of how easy or helpful the website was, there was no way I was looking through 85 plans. Like, no one is going to do that. I would have maybe considered the top 5 before I got tired of looking at all of this information. So then I went to the CMS website to compare some Medicare options. And I will say it's not as easy as just Googling, like, how do I get Medicare? Because if you do that, then you go to like the Social Security website, you end up with a couple different broker websites. So to finally get me to this point to help me compare the choices for Medicare, it was what much less straightforward than Googling how do I get Medicare. But when I finally got here, it let me choose, am I trying to find a Part C plan, a Part D, or a Medigap policy? And again, if you scroll over this little like question mark, it gave some like pretty straightforward information about the different kinds of plans. Next, it asked me, do I get help with my Medicare health or drug costs? So am I enrolled in Medicaid? Do I have SSI? Do I have a Medicare savings program, or do I get extra help? And these last two are specific Medicare savings programs that I didn't really know much about until like the past few weeks. And then it gave, again, the option to list like current prescription drugs and pharmacy preferences. Oh, I clicked specifically to look at Part D programs. And so I inputted that I was taking losartan, Eliquis, metformin, and donepezil, and that I wanted my local Walgreens to be included. It gave me 14 plan options with premiums ranging from $0 to $151, deductibles ranging from $0 to $590, and total drug and premium cost range. And this is for the rest of the year, $1,500 to $2,500. This is what it looks like when you just view one plan. You can see like the star rating, the monthly premium, the expected total cost for the rest of the year, deductible, what pharmacies. You can then click into the plan details and you can kind of compare plans side by side. It's actually, I found it really nice. You can view like yearly drug costs for each of your drugs. And if you had put in multiple pharmacies, you could compare across pharmacies. And it will actually tell you what your total drug cost is expected to be month by month. And so if you had looked earlier in the year before you're like meeting maximums and things like that, the numbers look a little bit different, but it can help you see how costs can change through the year. So honestly, again, a lot of information, but decent. So when that gets too overwhelming, because it is like for even 14 plans is too much to look through. This is why people turn to other people for help. So insurance brokers are advisors who usually represent multiple insurance companies, can help people evaluate plans and actively enroll them in plans. They have to be licensed in their states. They like complete annual trainings, and there's like a million rules and regulations from CMS that they have to follow. Some are employed by like one insurance company, but a lot of them are just like independent groups that contract with multiple companies. There is no cost to the enrollee. So then how do these people get paid? They get paid a commission by the insurance company that the individual chooses to enroll with. These commissions are typically higher for Medicare Part C or Med Advantage plans than Part D or Medigap plans. And the brokers often get paid like for the initial enrollment, and then again 1 to 2 years later if the enrollee stays in that same plan or stays with that same that same company. So there is some incentive to help choose a plan that is good for the person. Fascinatingly, you can actually look up the commissions that people get paid. There is a 141,000 row Excel spreadsheet that you can download from CMS that will tell you exactly what every single different plan will pay a broker in each state. I looked through it for like 5 minutes and I was like, you could probably get some really interesting information from this, but that's another grand rounds. This is just part of the rules and regulations for the brokers. I realize you can't read this, but one thing that I find hilarious is that brokers are prohibited from providing meals at marketing events, but they can provide refreshments and snacks. These are the important things that CMS and HHS are doing for us. State health insurance assistance programs or SHIPs are very similar to brokers. They provide advice, but they cannot directly enroll someone. So each county has their own SHIP that is an assigned organization that is a resource for people to get unbiased advice. Again, no cost to the individual. They are funded by divisions of HHS, so in part by the Administration for Community Living and the Office of Healthcare Information and Counseling. Very painfully, just in the past few days, I had to add this bullet point that the ACL was actually closed and canceled by HHS just earlier this week. They can also help individuals find out if they qualify for extra financial assistance. So that question that the Medicare website asked me about, like, do I have Medicaid? Do I qualify for extra help or Medicare savings program? The individuals at the SHIPs can help people make sure that they find out if they qualify for that extra help. The SHIP in Denver and Adams County is called Benefits in Action, and the SHIP in Arapahoe County is called the Denver Regional Council of Governments, or DRCOG. They also have like many other services at these agencies, but part of what they do is they are the assigned agency to be the SHIP in that county. This is just the logo for Benefits in Action. They have walk-in appointments, or you can call to schedule. So how can you help? I think this topic is really overwhelming because it's like we just talked about, it's really hard to understand all of these things. And even as a medical trainee, I feel like no matter how many times Kate or Josh explain to me what parts of stuff Medicare pays for, like I have to learn it again or I forget. And so I think it's hard when patients ask us questions because we don't always know the answer. I spent a lot of time over the past few weeks reading about like how do other countries do this, like reading about behavioral economics and choice theory and all these ways that people have tried to think about how we could make this easier for patients. In our survey, we actually asked, do you want someone to reach out to you and give you more help in this? And 75% of respondents did want someone to reach out to them, wanted some more help. So I thought about like, what are interventions we could do through the clinic to help our patients? And all of this felt like very overwhelming in a way that was not going to provide as much impact as I wanted to. So I tried to think like, what is something that is adaptable, because these numbers are also always changing, like the enrollment date, the open enrollment, and what's the out-of-pocket maximum this year, and the donut hole closed this year, and all this stuff is constantly changing. So you can't just make a fact sheet that is stagnant. It has to be adaptable. I wanted something that would be sustainable, that could continue, because I will be graduating at the end of June, and so I can't keep running this. And it needs to be relevant to our patients, right? We looked at like national numbers and even international numbers, but what does it mean for our patients in the seniors clinic? So I think one thing that's important is just to know the basics, right? Like we don't always have to know all of these numbers and all of these dates, but being able to explain to someone Medicare Part A, B, C, D, Medigap, Medicaid, I think those things are, even those basics can be really helpful to patients, because as we saw, like only 34% of our clinic patients that answered the survey accurately knew what Medicare Part D was. Know where to go for help, know how to Google these things. I think part of being a provider is knowing how to Google things well. And so knowing where to turn for help. And the UC Health Literacy team is a great resource for if you're creating a survey, if you're creating a handout, helping to make sure that that is appropriate for our patients. Refer to your local SHIP, especially for those with limited income. So I think honestly, that's my biggest takeaway from reading about this and spending so much time on this over the past few weeks and months, is that like, I can't learn all of this. And if I try to learn it all, I will just forget it all and then be wrong. And so there's someone whose job it is to know this really well and to help focus on that for my patients. And so I'm going to start referring to the local SHIP all the time. Fingers crossed that it does still exist in the coming months, but we'll try not to think about that too much. And I'm going to make a dot phrase so that my goal, I'm going to work with the health literacy team too. So this is in its draft stage. But I'm going to create a dot phrase for people to put in their AVS that says like the very basics, Medicare A, B, C, D, the local SHIP information, the website and the phone number. And I will demand that the incoming fellows take over this when I leave, so that it kind of sustains and can be reviewed every 6 months and make sure that the numbers, the links, the phone numbers are still correct. It feels like maybe a little intervention, but I hope that it's something that is easy for people to do, that doesn't make this topic too overwhelming, and will hopefully kind of make a big impact for our patients who need that like in the moment help, especially when open enrollment comes again. Thank you for your time. I think we have like 15 minutes for questions. Leo's also very overwhelmed.
Questions for Dr. Gates?
Where can we go to learn the basics?
What's that?
Where can we go to learn the basics?
Oh, Kate and Josh. No, that's a good question that I probably should have a better answer to. Yeah, I don't think I have a great answer to that. I would Google it. I know that's like so stupid to say, but I really feel like the CMS website is decent. Again, you have to like wade through a lot. But I like to, when my patients ask me questions, is to Google things. That's so bad.
I might have a suggestion.
Yay.
Hi, this is Risha Gidwani. Maddie, I'm so glad to hear your talk. I'm a health economist in the Division of Healthcare Policy and Research. I've been studying health insurance literacy and doing research in this area for a few years. So I'm so glad to hear some of the work that you've been doing as well. CMS has a website called From Coverage to Care, which is helps people understand what health insurance really is. It's aimed at the over 65-year-old population. I came from the RAND Corporation, and my colleagues at RAND helped CMS to create that. And I'll just drop the link in the chat. But it's admittedly a little bit more basic. It's more about like deductibles and co-insurance and co-payments. It doesn't sort of get into the most sophisticated aspects of health insurance literacy, but it's a good start.
Thank you so much. That's perfect.
Maddie, great talk.
Thanks.
I have more of a comment. I was surprised, you mentioned in the survey that respondents were really concerned about their current medications versus planning for the future. And I was struck by the website and how it really matches with where people are when they choose an insurance plan and not protecting themselves for the future. And I just think as a clinician, the majority of my patients, I am considering or recommending new medicines in older adults specifically constantly. There are very few older adults who really don't require adjustments in their medications. And so it's surprising to see that they're really thinking about current coverage of medications versus planning for the future, at least just in that specific, point.
Yeah, reading about the behavioral economics behind all of this, and it really stands out how people really don't even conceptualize in, not just in health insurance, but in other kinds of insurance, have trouble conceptualizing it as the goal is to protect you from future costs, not just manage your costs now. That's like across the board in all kinds of insurance, a concept that people struggle with.
What are some ways in clinic that you may bring up the concept of healthcare costs or healthcare literacy?
I think I try and think about it every time I recommend a new medication or a new specialist. It's hard because I also think I sometimes avoid it so that I don't have to have that play a role in my medical decision making. But I've also been starting to think about asking, I try to ask my patients to bring their medications to all of their visits. I've also been thinking about like making sure they also bring their insurance card with them too, so that if I don't know how much something is going to cost for them. Like when I was in residency, I could give people the phone number for them to call Denver Health basically to find out how much their medication would cost. But now taking care of people who have so many different plans, it's like impossible to look it up in the moment. And so having people have their insurance card with them so I can say, this is who you call or this is the website you go to find the information on what this would cost before you pick it up.
Hey, Maddie, this is back to the beginning of your talk. I was just really interested in the breakdown of the percentages of individuals who demonstrated health literacy and this sharp fall off in the oldest age group. And I was wondering that it looked like that information was from 2003, which would have been a very different generation that was in that age group than today. And I was wondering if there are modifiable risk factors since those are contiguous groups, the one just becomes the next. Do they lose health literacy, or was that a group that had less health literacy to start?
Ooh, I don't know. In other people who have looked at health literacy in older folks, there also is many things that I read were trying to break down like the different components of health literacy again, like knowing the terms versus being able to like make decisions. And different groups have found that different aspects of health literacy decline at different rates over time or change with, looking at the age groups decline over time. I actually read in another place that knowledge of terminology actually appeared to be a little bit more consistent over time, that people as they aged held on to that like crystallized knowledge better and then started to have more trouble over time with decision making, which is actually the opposite of what the study in 2003 found. So I don't know, I certainly don't know the answer. I don't know if maybe someone does, but some evidence shows that the decision-making part gets harder with time, and some people say that the terminology gets lost over time. And I wonder if that's maybe part of what we saw, is that age group in 2023 didn't have great knowledge of that terminology, but people that are aging now and are in their 80s now maybe have a better grasp of that terminology because of the things they learned when they were younger. That would be my guess.
I also want to make an observation that I find health literacy and health insurance is highly interprofessional in our geriatrics context. Like we've already been alluding and focusing on medications. I had a patient let me know that she was not interested in physical therapy because of the multiple copays. And then I've had others quite upset, like getting into the behavioral health and grief aspects and anger related to unexpected costs and pays and surprises.
Thanks for your talk. Really appreciated getting to learn something kind of new about health literacy and things. I wanted to ask a little bit about this topic from kind of like a branding perspective. There's a lot of like confusing language, or, there's a lot of terms that go into healthcare. And, like if a company is selling a product that customers don't understand, normally it would be on the company to kind of adapt to that, to change their language, so that the customers have an easier experience. But uniquely in a couple of industries, including healthcare, there is no incentive or pressure to change that. And I kind of wanted to ask you about your opinions on maybe meeting the patient in the middle, I suppose. The difference between educating patients in health literacy versus kind of a more of like an organizational change on simplifying the terms. Do you see things getting simpler from a system perspective, or is that kind of why there's a big push to increase healthcare literacy?
I do not feel super optimistic about this improving. There are technically like laws and regulations that say the government is supposed to provide resources to make this easier for patients. And that's part of like when the marketplaces were created, there was initially more funding for like navigators to help people go through these marketplaces. That was kind of part of the initial Affordable Care Act, and some of that funding has been lost over time. So technically there are rules that say the government, and it falls to states versus federal, but like are supposed to help people figure this out. And that is in part what the SHIPs are for. But it is certainly not a priority right now, or really has been even in the past few years, I would say.
On that note, what did you see any breakdown of the numbers in terms of how many people are using brokers versus SHIPs, or like how common is it really that our patients are using these brokers?
Yeah, when in our survey, we saw that 18% of people said they used a broker to choose their Medicare Part D plan. But then there was also a pretty, the 33% of people that said they didn't remember. So a decent number of people are turning to brokers. It was actually, I think, more at the seniors clinic than at Kavote or Lone Tree. The other interesting thing is at Lone Tree, there were clearly a decent number of people who have TRICARE. And so I think that the proportion of people in your population that have TRICARE and then don't even need to think about this makes a difference. But in our in our survey that we looked at, it was about 18% of people said they used a broker. We didn't ask about the SHIPs, mostly partially because I didn't know they existed. But I also don't know that patients really know about the SHIPs either, or would be able to know the difference between a broker and a SHIP.
Across your survey or your reading, Dr. Yusui asked how much info is available in different languages.
Ooh, very little. Sometimes Spanish. I mean, I think technically it has to be, no, probably not. there was sometimes options to click in Spanish, definitely in the Colorado marketplace, I think there was, but certainly not easily accessible and definitely not in anything that's not English or Spanish.
Thanks, Maddie. Nice presentation. I learned that I am largely health illiterate based on the questions you
It's
posted up
okay,
there.
we mostly all are. That's like the whole summary today.
My question is a bit more basic. Back to the one of your initial slides on literacy and numeracy. And you made the statement that there is a statistically significant reduction in literacy and numeracy in the United States based on that data. And there's two ways to interpret that, I think, probably more than two. Two easy ways to interpret that. One, our education system is getting worse. That's one way. Another way is that the demographics of the United States are changing, in that the age of the United States population is getting older, and the racial and ethnic backgrounds of the United States population is changing. And I'm wondering if there's any data on what is driving that reduction in literacy and numeracy, education versus changing demographics, because I think that plays into health literacy.
Yeah, I will say for this data, this was only people aged 16 to 65. So I do think looking at these numbers, that aspect of the aging population is maybe slightly less of a role, although there probably are a higher number of the 60 to 65-year-olds in the 2023 data versus the 2012. But I don't think I know the answer to your question. I have to imagine that it's multifactorial, but I do not know.
Yeah, and I guess what I'm trying to get at is there's, from the health literacy perspective, the data you showed suggests that the Hispanics have low health literacy. And so should we be targeting those specifically with low health literacy to increase the overall average health literacy or literacy or numeracy?
Yeah, I think yes. And actually in the Healthy People 2030, one of the objectives is specifically targeted at people who are Spanish speaking or people who do not speak English, reporting that they had better communication with their provider. So I think that is definitely an aspect that, if targeted, could raise the average for sure. And I think part of it is that a lot of this research is all done in English. And so when you're asking someone whose first language is Spanish to answer a survey in English and they do poorly, is that really reflecting their literacy? Because if you conducted that same test in their original language, would they perform much better? And so maybe what we're specifically talking about is health literacy for English. And then do we need to think about, should we be helping people have better health literacy in English, or should we be better at creating documents and conversation to match people in their primary language?
Fabulous discussion. Thanks for bringing this topic here.